Our first speaker tonight is Dr. Russell Stika. Dr. Stika is a board-certified podiatric surgeon. He focuses on reconstructive surgery and surgical and non-surgical treatment of all problems of the foot and ankle. He received his medical degree from the University of Osteopathic Medicine and Health Sciences College of Podiatric Medicine and Surgery in Des Moines. He went on to complete a podiatric surgical residency at St. John Macomb Hospital, Michigan, and a trauma surgery fellowship in Vienna, Austria. So please welcome Dr. Russell Stika.
Thank you, and thanks for coming. My name is Russ Stika. I joined Heartland Orthopedic Specialists in 2006. I've been in practice for 20 years now, 7 years before that in Michigan. And so I guess when I say 20 years, it really makes it sound like I'm kind of old. But it actually gives me the ability to maybe talk about some things that I have pretty good experience with, I believe. I have no financial ties to any company that's here. Everything you'll hear from me is really my experiences. So today we're going to talk, I've been tasked with talking about total ankle replacement in 20 minutes. That's a little bit difficult, but we'll try and get through it and be succinct. I guess total ankle replacement actually is a very interesting topic to me because it really spans my whole career. Over 20 years, we've seen everything from not having reliable implants to having some of the most cutting-edge implants with kind of ever-changing technology out there. So it really is an interesting time, and I've seen my practice grow to now doing 2 to 3 ankle replacements a month, which outside of the Twin Cities is really the most that's being done. So I can tell you from experience, it's been a very good addition to my practice. And over 10 years, really, of doing a significant number of ankle replacements, I can tell you that it's a very good option for patients. Tonight, we'll talk a little bit about arthritis, signs and symptoms, who's affected, a very little bit of ankle anatomy, some diagnosis and treatment options. Arthritis, obviously, joint inflammation. Lots of different types of arthritis out there. Whole list of arthritic problems. The top 3 on the left are probably the most common. And osteoarthritis and post-traumatic arthritis are probably the most common things that we will utilize ankle replacement for. And it's the post-traumatic patients that really is where ankle replacement kind of hinges around, because in traumatic arthritis, you see a lot of angular deformity, and that has been the pitfall for ankle implants that have been out there previously. And with the newer implants that are out, we're able to address a lot of different deformities. So it's really been a promising thing. What is osteoarthritis? Basically, degenerative joint disease is another name. It's the most common form of arthritis. Affects a whole lot of people. It's expected to affect 60 million by 2030. It's a wear and tear condition. It's overuse injuries. It can be repetitive movements. You can have developmental disorders that result in angular deformities or contractures that result in unusual wear of cartilage, and over time you develop bone-on-bone arthritis. So arthritis, and many of you probably have arthritic joints, starts fairly simply as the joint is warm to the touch, joint swelling, joint pain and immobility, joint stiffness. And really what happens is the inner lining of the joint capsule thickens, forms these finger-like projections that kind of get caught in between the 2 bones that are articulating. And then you get fibrous bands that form across the 2 bones, and you get stiffness. And long-term, the cartilage wears away and you'll develop joint deformities. And what I mean by joint deformity is, if you look at the left-hand side, you see a relatively normal-looking ankle joint with a nice black space between all those bones. And on the other side, you see a very angled joint, and basically that's a chronic ankle sprainer seen much later in life. You can develop that bad of arthritis. So joint deformity is pretty important when you start looking at ankle replacement. Demographics, it really does not discriminate. It affects all kinds of people across the spectrum. Ankle joint anatomy, very little anatomy. You only have to learn bones tonight, and that's the big shin bone called the tibia, the narrow long bone on the outside called the fibula, and the talus bone. The talus bone is that dense little bone in the middle of the ankle, and that's the most important bone because that bone has a very friable blood supply. It's involved in the articulation at 3 joints, and it really has been the reason we've had difficulty in developing implants for the ankle joint. Again, osteoarthritis. On the left-hand side, you see a joint where you don't see much space, much black space around that talus bone, and on the right side, you see a nice black space. The black space is cartilage. So if the black space isn't there, the cartilage isn't there, and you have bone-on-bone arthritis. What are some treatments for arthritis? Many of you have probably been through these. Simply non-steroid-based anti-inflammatory medications, Motrin, Aleve, that kind of thing. Corticosteroids. Corticosteroids can be injected into your muscle to give you whole body relief of inflammation. It can be injected into the joint, your typical cortisone injection. Physical therapy can be helpful, strengthening and stretching, helping balance out different deformities that maybe you were born with or developed from an injury. And then, of course, bracing. Bracing can be quite helpful, especially with the ankle. And basically, a brace restricts the motion across the joint. So if a joint is bone on bone and it's rubbing, if you limit how much it's rubbing, you're going to limit how much inflammation and how much pain you're going to have. So bracing can be a viable option. It obviously does not fix the problem, but it is an option that's non-surgical. From the surgical side, arthroscopic debridement, or cleaning out the ankle joint, is a procedure that's out there. I don't do a whole lot of that because it really is a temporary fix. If you're looking something to buy you time, that may be helpful. Back before 2005, arthrodesis, or fusing the ankle joint, was really the procedure of choice. And it worked very well, and it's been around for decades and decades, and it took away the pain. But imagine how you function when you have a fused ankle. So if you lost that ankle joint motion, it's relatively significant with regards to gait. And then, of course, we have total ankle replacement. So what is total ankle replacement? Basically, you're capping the 2 ends of bone, in this case, the tibia with titanium and the talus with cobalt chrome, and in between that is a polyethylene spacer. The polyethylene spacer wears over time, and so that's what we always think about when we're talking about replacement of any joint is, how long does it last? What are the benefits? So if we go back to thinking about fusing that ankle, if you take away ankle motion, motion is in a joint to dissipate energy. If you take away that joint's ability to dissipate energy, it gets shifted to the next joint. So if you fuse an ankle joint, eventually you'll have some arthritic problem in a joint away from that fused joint. But again, it did take away the pain, and back before 2005 or so, it was the only option we kind of had. It's designed to closely replicate normal gait, and it actually feels more natural to the patient. So those are kind of the benefits. The current market is kind of ever-changing, actually. Even since I made this slide, things have changed a little bit. On the top left side is an implant called the Agility implant. It was designed by DePuy, was around for actually a lot of years, through the 90s and into the early 2000s. Put several of these in, but it was really designed for an elderly, very sedentary patient population. So it really wasn't great for a lot of patients. If you go from bottom left up to the top right, those 3 implants in 2005 and on really have kind of been what changed ankle replacement. And then there's an ever-changing implant market out there in which they're trying to get lower profile implants. And Zimmer has one in the bottom right there, and there are a couple of others that are out there that I consider to be joint resurfacing implants. So they've gone away from having a stem, which you see that middle implant has a pretty large stem. The bottom left implant has a fairly large stem. In my opinion, that's a pretty important part of this whole process because that stem gives us more vertical fixation, it's called, and we can put that in much younger individuals and much more active individuals. So the science of the total ankle really has evolved from that implant. The agility implant was designed where you actually had to fuse the tibia and fibula together to give your rigid fixation for that implant. Well, so that really depended on you achieving a fusion of those two joints, and it didn't have a stem, so you didn't really have that vertical fixation, and so it wasn't a very stable implant. So we saw problems with that. So having a stem, I believe, is very important. Having modularity to the implant, so being able to build the implant. With that stem, we can actually build how tall that stem is, how long it is. We can pick different thicknesses of different components. We can pick thicknesses of that poly, and we can pick different stem lengths for the talar component. So the whole reason we're kind of here, how do we improve our accuracy? That's really kind of the cutting edge part of this. And you're going to hear from Dr. Feierabend, who's going to talk about robotic surgery, which really is on the one end of the spectrum, and ankle replacement surgery is kind of new. So we're at that middle point where knees and hips were years ago, when we start using CT-guided system. So we actually, this is called Prophecy in-bone ankle replacement. We actually get a CAT scan of the patient's ankle. We then computer generate a 3D model of the patient's anatomy, and then plan the implant placement, and then actually make a 3D alignment guides that we use in the surgery to align our cutting block. And so this is making a more precise implant that we hope, if it's precisely placed, will last a lot longer than if it wasn't placed that way. So I wanted to take 5 minutes here to show this, because it just gives you a good idea of what the surgery is. There is no sound, so sorry. That is actually called the cutting block that was placed using those jigs. So we're just removing the arthritic portion of the ankle, 2 different pieces. This is now called the talar alignment jig, and the cutting block is placed. And we remove the top portion of the talus. Then we place a tibial alignment jig. So we're going to drill a hole up through the bottom of the foot into the tibia, and we place a special thing called a foot holder. And this is all done with fluoroscopic guidance, so C-arm X-ray is utilized throughout the surgery. So 1 incision on the front of the ankle and 1 small incision on the bottom of the foot. Now this is reaming, so we're reaming for that stem, reaming the tibia. This implant is coated with a special coating that allows the bone to grow into the implant, which is a little different than knees and hips that are cemented in place. So now they're building the stem out of component pieces. So again, we can make that as long or as short as we need to. So everything goes in through the front of the ankle. It's kind of the pitfall of some of the very old stemmed implants was you couldn't get them into the joint. You had to cut a window in the front of the tibia bone to get it in. And this would be a trial for the plastic spacer, and then that's the tailor component trial. So we check and see what the right size is just to make sure the computed guided system was correct. And we ream, there are 3 stems on the bottom of that component that are basically into the talus. This is just called a poly insertion tool. So it's putting that plastic spacer in between those 2 pieces of metal. And that's the piece that wears over time, and that's the big question. How long does a poly wear? I've seen people that I've done 10 years ago, I've seen them back, no signs of poly wear on them. We have studies 15 years in Europe and about 10 years here. You know, we really think the poly wear is significant in length, but we really can't say for sure how long. I'd like to think it's 20 years. Worst case is if it wears out or breaks, you would have to replace the plastic portion. Thanks for putting up with that little video. I think it's helpful sometimes. So pre-op, post-op, these are just some examples. Pre-op on the left side, patient had an ankle fracture previously, resulting in post-traumatic arthritis. Right side is actually in-bone 1. That was actually one of the first generations of this right medical implant. Just another example, another post-injury arthritis that's resulted in ankle replacements. And in this case, we could leave the fixation in place. We didn't have to go take anything out. In this case, there's part of a screw left in the middle of the tibia, and that's exactly where our stem needs to go. So we had to go fish that out first and then put the implant in. Just another view, side view of a different patient. Really, you know, what we're looking at now and have been over the last 5 years really is alignment. Just like we talked about alignment, maybe lower extremity alignment with knee replacements. Well, we have to look at hindfoot, the back part of the foot, and its alignment when we're putting in ankle implants. There's a lot of people that have severe flat foot deformities or a cavus foot, high arch, flat foot. That needs to be addressed. Otherwise, your implant is not going to wear and is not going to last as long. So we see a lot of adjunct procedures going on along with ankle implant just to help the longevity of the implant. So what's the postoperative course? 1 night stay in the hospital. The surgery is done under either a spinal or a general anesthetic. You stay overnight 1 night. I would say 95% of the patients go home after surgery. Some go to a nursing home for a short stay. You're in a splint for 4 or 5 days to allow for swelling. Then we put you in a short leg below the knee fiberglass cast for 2 weeks. We then have you come back in, remove sutures or staples, and recast you for another 4 weeks. So the hard part of this surgery is 6 weeks of not walking. That's how it's different than knees and hips that are cemented in place. So that's kind of the hard part. Walking boot then for 2 to 4 weeks, and then we put you in an ankle brace, and that's kind of used as needed. If you're an active person, we would ask that you wear that ankle implant or the ankle brace as needed. That's kind of all I have at this point. I guess if there's any questions, we can field those now or later.
Have a question? Just raise your hand.
Sure. Yep.
Hang on, I'm coming.
She's coming.
That totally looks awesome, but 2 questions for you would be, you already addressed the life of the actual the actual implant there, which I am astounded after 10 years there's no wear, so that's very promising. What's your assessment on the limitations? Say you put this into somebody my age, or go to the extreme, somebody in their 20s, go back in the 80s, David Lee Roth. Will you still be able to do the taekwondo and the rock climbing and everything else?
Right.
What do you foresee if it needs to be replaced again?
So that's a good question. That's a very common question. It's one that, you go into this surgery, everybody has their own thing, their own activity. If you were someone that wasn't a runner beforehand, I'm not going to tell you to take up running, and I'm not going to tell you to take up marathon running, because anything that pounds that implant is going to have an effect on the implant. But really, I've done this on, you name it, I think we've done it. Farmers, wear and tear is huge, jumping in and out of tractors, truckers jumping in and out of trucks. We try to teach those people. They do physical therapy towards the end of their recuperation time, and it's really important to talk to those people about, if you drive a cement truck and you always come down on the same ankle, maybe we need to retrain that. So we really look at the whole picture as we go through this process, and I think Dr. Feierabend maybe will jump into that a little bit with the Joint Replacement Center, because that's really, what they think and talk about, and it's all about teaching. So running would be a big one that I would say you shouldn't take up. Doesn't mean you can't run across the field if you need to. It's just the repetitive things probably will have significant wear and tear. Cycling would be better, correct? Yeah.
So is there a lot of disruption to the tendons and ligaments on the outside of the ankle?
Yeah. So that's a good question. Is there any disruption of the ligaments and tendons? And actually, we can honestly say no, because our incision is right down the middle. Everything is moved to the side. We do cut through the capsule of the joint, and that joint capsule has a significant degeneration anyway from the arthritis. And we do look at ligaments, though, when we do this, because if you had a loose ligament on one side or the other, you may have to tighten that up or repair it. So we do look at that, but in general, we don't disrupt those things. Anyone else?
One last question from anybody? Oh, there's one down.
So obviously this differs from patient to patient, but what is the average course of physical therapy that you recommend after? How many weeks is typical for your patients?
Yeah, so that does vary, obviously. The easy answer is as much as it takes, because there are some people that obviously will take a lot more than others. And there are some physical therapists here that can probably answer that question maybe even better than I can. They obviously, I would say the majority of patients do go through formal physical therapy. It's typically 4 weeks in length, 3 times a week for 4 weeks, and sometimes longer for people. They're given a home exercise program, again, more training and teaching about what to do and not to do, and advancing them then into their brace and so forth. So kind of a tough question. I would say 1 to 2 months.
Sounds good. Thanks.
Yeah.
All right. Thank you, Dr. Stika.
Thank you.
All righty. Feel free to stand up if you need to, stretch out a little bit. I'm going to introduce our next speaker, so we'll get started right away. We're happy to have our next speaker who joined the orthopedic practice, as he's been such an asset to the group and the patients in our area. Dr. Sig Feierabend's education is a bit unique. He has a master's degree in mechanical engineering from North Dakota State University, in addition to his medical degree from the University of North Dakota. Dr. Sig completed his orthopedic surgery residency at Wayne State University, and his current orthopedic practice specializes in shoulder and knee repair, hip and knee replacement, and general orthopedics. So please welcome Dr. Sig Feierabend.
That's a further walk than I thought. I'm sorry. Okay, good afternoon. Thank you for coming. My name is Dr. Feierabend, Sig Feierabend, usually just go by Sig, and I'm giving you a little bit of a talk today on general arthritis and then some new technology that we have at Alomere Health now. Just a quick pitch for the rest of the group here. We do cover everything at Heartland Orthopedics. We have sports medicine, joint replacements, shoulders, ankles, hips, knees. We do take care of trauma, hip fractures, broken bones. We do a lot of hand stuff, degenerative things, tendon issues, etc. Osteoarthritis, Dr. Stika went over a bunch of this as well. Discussion about malalignment, things coming out of correct alignment and then wearing out of the cartilage. There's many different reasons for it. He talked about the osteo, the rheumatoid, the post-traumatic. Again, there's many different reasons, but a lot of times what happens with a joint is that the alignment, that the correct pressures across the cartilage change. People get bow-legged, they get knock-kneed, etc. And that leads to weird or strange pressures on the cartilage that it's not used to, and then it leads to osteoarthritis, which is the most common thing that we see as far as arthritis. Again, pain, stiffness, debility, and then you end up seeing one of us. Here's a picture I like to show some people too. A lot of people ask about different supplements, injections, whatever else. Is there anything short of surgery to fix arthritis? And so that picture on the corner there, that's actually a femoral head, so a hip bone that has arthritis in it. So if you look at it, it's supposed to look kind of like a cue ball that you play pool with. It's supposed to be smooth and white and perfectly round. And if you look at that, this is what we see every day when we do hip replacements. There's potholes, it's not round, there's red areas where the blood is coming into the joint, and it just looks painful looking at it. But injections and things into the joint can help the pain part, but there's nothing that we can do yet that can reshape that bone and make it round and put the cartilage back on it. So there are things, again, the lubricants, whatever, but as far as getting the cartilage to grow back, we have to figure out how to make that ball round first. And again, at Heartland, we do things like hip arthroscopies and things where we can kind of reshape the ball a little bit. But once the cartilage is gone, we don't quite have the way to put it back yet. First thing about arthritis or any type of joint pain is getting the right diagnosis. That's where you come see your doctor. X-rays are something we commonly get first, just a plain film to see, is that black space there? Is the cartilage still there? And then a good exam often gives the diagnosis as well. This is just another X-ray, just like Dr. Stika showed with the ankle. You can see on the left, normal, that black space is filled with something. It's not nothing, it's just cartilage. On the left is a normal knee, and you can see that it has good alignment. Everything is nice and straight. The space is even going across it. And on your right, you can see how it's wearing out more on one side, and the knee is starting to get out of alignment. Kind of like the Leaning Tower of Pisa or something tipping over. The more it tips over, the faster it tips over as the pressure on that wearing outside gets even higher, increasing the rapid rate of degeneration. Same thing on a hip. And this is things that we can see just with a plain film. You see a nice round ball on that left side with normal joint space. The bone is pretty much even gray, which means how much radiation gets absorbed when the X-ray goes through it. On the right side there, you see how it turns white and the space disappears. The bone is actually reacting to the extra pressure and it's getting harder so that it doesn't wear as hard. The body is trying to protect itself by getting harder so it doesn't wear out once the cartilage is gone. Cartilage does not have nerves or a blood supply either, so it doesn't really heal. But the good part is it has no sensation. You can overload cartilage as much as you want. As long as it's there, it doesn't hurt. Once it disappears, the bone that's underneath it has a very good blood supply and it has a very good network of nerves, so it hurts. Like anybody who's broken a bone knows it hurts. And when you're grinding bone on bone, that hurts. Here's just a bunch of the non-operative things again. Diet, exercise. If you decrease weight, decreases pressure. Cortisone injections, Synvist injections. People try many different supplements, green teas, turmeric. You can take glucosamine, chondroitin. You can try all of these. Not many of them are supported with good randomized controlled trials. So what I tell people is, if you're going to try a supplement, try just one. Say, I'm going to try glucosamine, chondroitin, whatever it is, and just one thing. Don't say, I'm going to lose weight, I'm going to take ibuprofen, I'm going to walk, and I'm going to take glucosamine, chondroitin, and say that's what caused the benefit, okay? And make sure you get them from a good source, like Costco, Target, Sam's Club, etc., because they actually verify that what's in the supplement actually is in there. Because anybody can sell anything and say whatever it is. The FDA does not regulate supplements, okay? So make sure it's reputable. Icing, rest, raising it up, etc., to help swelling, physical therapy. Joint replacement. Once it comes to that point, usually that's a last resort. People aren't a big fan of having surgery. There's pain involved with surgery, there's recovery, there's cost, there's planning your life around it, especially like Dr. Stika said, an ankle replacement, you're off of it. Hips and knees, we get you walking right away, but there's still a recovery period, a period off work, lost wages, etc. So once everything else has failed, we kind of get to that point, joint replacement. Benefits of it, again, once you've made it through the surgery, once you've recovered from it and you've got your range of motion and the healing period is over, the idea is to get you back to your quality of life that you had before your knee or hip wore out. You can get more motion out of it, you can sleep better, you can walk better, you can do more activities. And of course, we find the most athletic people to take pictures of. Knee replacements, here's just an example of that. Again, like an ankle replacement, a hip replacement, a knee replacement, the idea is to remove the bone that's touching bone and replace it with two very smooth surfaces. The best surfaces that we've really found are cobalt, chrome, or ceramic that can be polished very, very, very smooth and rub on a very, very dense plastic called polyethylene. And there's things we can do to make things smoother and make the polyethylene more durable by cross-linking and chemical things. But it's about the same material as it's been for the last couple decades. Hip replacement, same thing. We've changed some things, designs of the implant, but it's still a ceramic or a metal, very, very highly polished on a wearable surface. Again, polyethylene seems to be the best thing ever. They've tried other things like cements and Teflon and other types of plastic, but this has been kind of the gold standard for many decades. Risks and complications, again, with any surgery. So this kind of brings us to my part of the talk here. Being as the materials have not gotten much better, we're at a really good place with the wearing of the ceramics, the wearing of the titaniums, the polyethylenes, and the cobalt chromes. The big thing that we can do is to try to bring the joint back to the alignment that it was supposed to be in. So the idea of a joint replacement, anything, is to replace those surfaces that are bone on bone. But if you don't correct the alignment, if you don't bring the patient back into a neutral alignment, correct the knock knees, correct the malrotations of the hip, whatever, it's hard to bring them back into alignment. Traditionally, what we do is we take x-rays in the office, we draw lines on there, but we're taking a three-dimensional object, your hip, your knee, your tibia, and we're putting it into a two-dimensional picture. And that is what we're templating from as to how to place the components in you and correct your alignment. So one of the technologies that we've got at Alomere Health is the Mako robot, when it's a way to take that three-dimensional object, put it into a three-dimensional space, and then correct that deformity in 3 dimensions with the robot. And this is based on preoperative templating with a CT scan versus just a flat 2-dimensional x-ray. So if some of you walked by there and you saw the robot in the corner there, that is just a tool that we use. The big advantage of that robot is not that it's a robot and that it keeps you in alignment, makes the cuts, but it's that it takes a 3-dimensional image. We do a CT scan of your hip and your knee. When we do a knee replacement, we even include your hip and your ankle so that we have a 3-dimensional representation in the software before we even get to the operating room, where we can correct your deformity and then place the implants virtually before we even start the surgery. Common questions, just some things people ask. How long has it been available? About 2 weeks, never been used before. Just kidding. It's been out over a decade. This number was 80,000. I just asked back there. They said it's over a 250,000 joints have been done just in the US with the Mako robot. It does not do any of the surgery itself. It's a tool. It holds the instrument that you're using, a saw blade or a burr or a reamer. It holds it in the correct orientation, but the surgeon is the one who actually operates it, starts it, and moves it. It just is a helpful guide. Something I describe people as like a drill press versus drilling a hole with a handheld drill. It just helps you align it. So again, before the surgery, that CT scan of the hip is done. So when you come in and we talk about a robotic joint replacement, I set you up to my scheduler. She sets you up for our joint class. She sets you up for your pre-op labs, and she sets you up for your CT scan. That all gets pre-op done before you ever go to the operating room. When we do, before you ever have surgery, this is what I get to see, is a virtual 3-dimensional model that can be rotated of your knee or hip, whatever's being replaced. I'm just starting with knee here. And the size of the implant can be fit before we ever make a cut on the skin. On a hip replacement, sometimes people wonder, can you do different approaches, or is this robot specific, or does a robot only do one trick, or whatever it is? The robot does not do the soft tissue part of the surgery. It just helps place the implant and manipulate and interact with the bone. Any of these approaches can be done with the robot. So I do anterior lateral and those direct minimally invasive hips from the front, and I use the robot for those. They also can be done posterior. The other doctors use the robot for those as well. Here's a hip replacement. Again, more information you can see. These are slices of a CT scan. So a CT scan, you get shoved through the donut, slices you a bunch of pieces, and I can look at all these pieces. And then virtually, that green thing is the cup side of a hip replacement, and I can see how much bone is being removed and what the quality of the bone is where it's being placed. So on that picture on the right, you see that green C, and above it, you see that weird little spot. That's a cyst in the bone. And I can see that much better on the CT scan and make sure that the cup has good bone to interact with. Same thing on the other one. That's a slice the other way from the CT scan, and I can see how much bone and make sure that that cup has a good fit in your pelvis. Other side the same way. That's the stem side of a hip replacement. Slice by slice, we can see how it fits, and that's how we size it beforehand. And then once all that's put together, you get a nice 3D model that you can rotate around. You can see how it fits. You can see how it looks. And then we take both hips too, so I can make your leg longer, shorter, more offset, less offset, and make sure everything is where it needs to be. And what this does is in the hip and knee, it corrects that 3-dimensional alignment so that you can decrease the risk of the implant wearing out. Again, higher pressures wear out the plastic, and then we talk about revisions. But if you can restore that 3-dimensional alignment, the joint feels more natural and it lasts longer. And the accuracy is very precise. In that bottom corner, you can see we're measuring to the nearest millimeter, which is kind of crazy. In the operating room, once we get in there, once we've done all that pre-op templating, we've looked at the CT scan, then we actually do the surgery. What the robot does is just allow you to operate the tool in that predefined path. So on the left there, you see a hip. So there's a reamer. I know what size cup is going in there. I put the correct size drill bit on there to make that hole. And then the robot keeps it lined up at the exact angle to the exact depth. And if it goes out of there, the robot just stops. I'm still advancing the robot. I'm the one who pulls the trigger and lets it turn, and I'm in control of it as it does it, and I can watch it in real time as it goes into the pelvis. When I did hip replacements before, I used X-ray as I did that to see where the reamer was going. Again, that was taking a 2-dimensional picture to see where it was going, but I could take multiple 2-dimensional pictures to see. So this decreases the amount of radiation I'm exposed to, you're exposed to, and it gives me a 3-dimensional instead of a 2-dimensional picture. On that far right side, you see a total knee. That blue shadow is the saw blade as it's advancing across the tibia. And that little green line is a haptic line. If you were to fight the robot and try to get out of there, it would just turn off. So there's no way you can really cut anything important. Here's a picture of the actual robot arm with a reamer. Again, my hands are on it the whole time. that my hand is literally on the trigger. It won't run without me pulling that. One more thing, pitch for the robot part. On the left, you see the robotic arm. It holds the saw blade and it only goes in that plane. Traditionally, once I've planned where the implant goes, I pin that block that you see on the right in place, and then the saw blade can only go through those slots, and that's what makes the alignment. Again, from a two-dimensional, I place the implants that way, which works good, but it's not three-dimensionally CT placed. It gets more accurate alignment using a CT scan. So after surgery, here's just some things that we do. Total hip that we can do with the robot. Total hip, partial knee, medial or lateral, or just the patellofemoral joint. Some patients are candidates for just a partial knee replacement as opposed to a total knee. So if you've only worn out on the inside or only worn out the patellofemoral, there's no real reason to replace the whole knee if you don't have to. So the robot makes that easier to do partial knees or total knee replacements. Last couple things is just, again, if you know your surgeon and you have good outcomes of what a knee replacement is, you should have a good outcome after knee replacement. It's a very successful surgery. We do a good job here. We have a great joint camp. We have good support. What I tell people is that Alomere Health is kind of like a machine for joint replacements. Everybody is on board. We do lots of them. There's no surprises. All the nurses have seen everything before. We do nearly 1,000 joints every year. We're just all on board with what's happening. So it's a good place to pick to have your joint done. And lastly, if you know your surgeon, there's no reason to switch to somebody else just because somebody's saying, oh, I got the greatest thing. If you know Dr. Dale, if you know Dr. Dudley, Dr. Weigel, whatever, they do a great job. They have good outcomes. So it's very important to trust your surgeon that's doing your surgery. And that's all I got. So if you have a question, rather than making Angie run, yell it out, and then I'll repeat it to everybody else, and let's take like 2 or 3 questions. Anybody? Yes.
I have a question. If you've had total knee replacement on both knees, can you kneel on your knee? Should you kneel on your knee?
So the question was, if you've had a knee replacement, should you or can you kneel on it? Many people say, I can't kneel on it because the scar is on the front of the knee and it's sore. There is no reason you cannot kneel on it. The implant is solid, the bone is solid. Just some people find that kneeling on that scar is painful or they don't like it. But there's no medical or mechanical reason you cannot. One more? Nothing? Thank you.
Well, you're not done.
I'm done.
Oh.
I'm done.
He's too fast.
All right, how's everybody doing? Good. So our last speaker tonight is Dr. Emily Monroe, who joined the practice last fall. We had been eagerly anticipating her arrival, or return home, I should say, for some time, so we're really delighted to have her here tonight. Dr. Monroe is a fellowship-trained sports medicine specialist with an interest in knee ligament reconstruction, shoulder arthroplasty, and minimal invasive joint arthroscopy. She received her medical degree from the University of Louisville and completed her orthopedic surgery residency at Northwestern University in Chicago. Please welcome Dr. Emily Monroe.
Well, thanks so much for coming. I get the opportunity to talk to you today about shoulder pain and different treatment options. So we'll be going over a little bit of the anatomy, and then I'll try and hit the most common diagnoses that I see for patients and what's commonly done for them. So the shoulder is a shallow ball and socket joint. The socket is deepened by some cartilage called the labrum. It's a circle of cartilage. What people are most familiar with is the rotator cuff, which actually the portion of the shoulder you can feel called the acromion. You can see it there at the very top. Underneath that lies a bursa, and then beneath that is the rotator cuff. Another common thing that you can feel on yourself is where the collarbone or clavicle meets the acromion. And so first, to touch on the rotator cuff, there's 4 muscles that make that up. They include the supraspinatus, the infraspinatus, the subscapularis, and teres minor, and then their tendons. So these all combine to form a cuff over that ball portion. And actually, when you dissect these in cadavers, they're very difficult to distinguish from one another, which is why we call them a cuff. They function to lift and rotate your arm and stabilize your shoulder, but they also can be a source of pain. There's a continuum of shoulder pathology that can occur. Because when you bring your arm up, it starts to almost impinge on that acromion as the head encounters that portion of the shoulder blade. That's something we term impingement, and it sort of pinches the rotator cuff. And as a consequence of that, you can get irritation or inflammation of the tendon. We call that tendinitis. And along with that, you can get bursitis, where there's inflammation of that overlying bursa. So that altogether can cause pain and difficulty moving the shoulder. And in some cases, this can actually cause tearing of the rotator cuff. Partial tears are more of a fraying and that there's no discontinuity of the tendon. But when we see full thickness tears, it means that the tendon is no longer attached to the head, and that tends to be a little bit larger of a problem. Most people, when they come see me, have very similar complaints, in that they have maybe difficulty raising their arm, either because of pain or because of weakness, and often wakes them up at night. Some people feel a grinding sensation as well. And some people can have a fall where, all of a sudden they can't lift their arm and it doesn't work the way it used to. And some people it develops over time, and you can't pinpoint a direct time when it started bothering you, but things eventually reach a point where you need to see somebody. Often, if the rotator cuff is not completely torn, I recommend doing some non-operative things first. That usually consists of injections or physical therapy, and really a lot of people see much relief with physical therapy and those injections. But if that's not successful, sometimes we have to do surgery for that. More often for me, that's arthroscopic, but open is still an option. Tends to be come and go, same day procedure. And if there's no tear in the rotator cuff and we're just taking out that inflammation, recovery is fairly rapid. That's why we call it more of a 6-week plan. That you spend some time in the sling just until the shoulder feels comfortable. I get you into physical therapy, and typically people are getting back to their usual activities by that time frame. If there's a full tear in the rotator cuff, actually oftentimes physical therapy can be beneficial if you're someone that really wants to avoid surgery. But if you have surgery and I have to repair that tendon, we have to give your body adequate time to heal that. So unfortunately, it requires 6 weeks in a sling for me. And after that, you have to spend a lot of time with the physical therapist to get to know them very well and getting your motion and your strength back. So usually more 4 to 5 months, but even up to a year, people are still making improvements after that surgery. That's why it's such a big commitment that you have to kind of make that decision and decide when it's really bothering you enough to do that. Here's just an arthroscopic pictures of a rotator cuff tear. On the left side, we're looking from the very side of the shoulder into the shoulder joint. If you look very deep there, you're seeing the cut portion. And more in the lower portion of the picture is the head. And then if you can kind of see, there's that beefy looking tissue, that's actually the edge of the rotator cuff. And so that's before any repair has been done. And then on the right-hand picture, you can see kind of a mess of sutures, but essentially the idea is that we're pressing that rotator cuff down onto its insertion point and giving your body a really good chance to heal that back. So the next thing I'll talk about is instability. As I said before, it's a little bit of a shallow cup. We sort of, one of the analogies that we talk about is a golf ball on a golf tee. It's probably a little bit better than that, but the labrum actually helps to deepen that, and your rotator cuff really does a good job of stabilizing the shoulder. So people can develop instability usually as a result of an acute injury. So they sustain a dislocation where the shoulder comes out of place. It depends a little bit by age group how they're treated, but in general, physical therapy tends to be a good way to start. And the injury depends on what direction the dislocation occurred or what sort of injury you had. So most often we're seeing those in the front or the anterior portion of the shoulder. And it tends to injure the labrum. Sometimes it injures the bone, and most often it injures the ligaments as well. Another thing that people often hear about is called a SLAP tear. It's an acronym that stands for superior labrum anterior to posterior tear, and that's at the top of the shoulder. So here's an example of a slap tear. You can see on the left-hand MRI image is actually a normal image, that labrum that they're pointing to is connected very nicely to that to the cut portion. And the image on the right of the MRI images has dye in it, and that some of that dye is going underneath where that labrum is, so you can tell it's not attached. So most often with my patients that have labral injuries, activity modification and physical therapy are the places that I start. And avoiding sort of the things that put you at risk of feeling a sense of instability or pain with that shoulder. And physical therapy helps to strengthen the rotator cuff, which, as I mentioned, really helps to stabilize that shoulder and help it move in place. But if all those things fail, surgery can be indicated for these individuals. Here's some examples of arthroscopic pictures again. On the left is a normal exam. So the biceps, you have two heads to that. One actually goes all the way inside your joint and attaches to that labrum. And you can see the labrum is kind of coming around. So you're viewing the very top portion of that glenoid or that socket. In the middle picture, there's a pretty large tear of that labrum. You can see it pretty obviously. And then in the right hand, as you can see, it's been repaired back. So sometimes that is required. Another common problem that I see in folks is what's called frozen shoulder. It's technically called adhesive capsulitis. And people present with a stiff, painful shoulder that just is not moving and very painful. Happens in about 2% of the population. Most commonly I've seen it in women, 40 to 70, and it's associated with things like diabetes and thyroid disease. We haven't quite determined what all causes this, but essentially what happens is that the shoulder capsule or the lining that surrounds it gets thickened and gets very inflamed. And because of that, it contracts down and gets smaller, so the shoulder will not move as well. And fortunately, it's a self-limited process. It's just a long time sometimes. Sometimes we're looking at 2 to 3 years before people are feeling 100%. But there's things we can do in the meantime to make you feel better. And usually that consists of physical therapy and injections. And in very rare cases, maybe 5% people require surgical intervention for that. And the final thing I'll talk to you about is arthritis. And as Dr. Feierabend touched on, it's kind of a wear and tear problem. That's how we think of it. And it can be due in the shoulder to a number of reasons. One is similar to the hip and knee, that the cartilage just starts to wear out. Maybe you're a heavy laborer, maybe you lifted a lot of heavy weights in your day. Those things all sort of predispose you to that. Other things that can cause arthritis are long-standing rotator cuff tears. So if the shoulder, you may not know that you have a rotator cuff tear, but if it's been there for a while, the shoulder is not functioning as it should and will wear out as well. And most often people are telling me about pain. They kind of have that popping and grinding sensation. And also their motion, they'll say, well, it's kind of gotten worse over time. I can't quite reach my back pocket like I used to. And those are very common things that people talk to me about. So there's a number of different shoulder replacement type options. In very young patients where their disease is isolated to the ball side, sometimes they're able to just do a partial replacement. So you can see here that it's a very simple implant, but again, it's pretty limited indications for this particular one. More commonly, we talk about doing the total shoulder replacement. And you see this one looks like, the anatomy should. And the cut portion is not very large, so we're not able to use metal and plastic. We do use a plastic piece. If you look very carefully on that x-ray on the right, there's a little bit of a marker in that cup, and that kind of shows you where that is in space. But the total shoulder relies on a rotator cuff being intact and functioning well. So if it's not working well, your shoulder is not going to move as it should. And in those cases, we've developed something called the reverse shoulder replacement. And this one acts by essentially reversing the anatomy so that instead of the cup being on the cup side, it's on the ball side. And what this does is it changes some of the mechanics of the shoulder so that some of the bigger muscles, such as the deltoid, the big muscle on the side of your arm, can take over the function of the rotator cuff. So it allows those patients that do not have an intact rotator cuff or one that's not functioning well to still have a good result with this. It's not been around as long. It's been around since 2004 in the United States, but in Europe has had a much longer track record. But as we're improving our techniques and the implants that we have available, the outcomes are very good for these patients. So I often can't tell by looking at you what kind of shoulder problem you have. There's a lot of overlap in what people talk to me about for these different conditions. So talking to you about any injuries, what your symptoms are, overall health, and what sort of activities are important to you are very relevant to our decision-making process. I always examine in terms of how your range of motion and strength, and some other special tests that help me determine what else is going on. But x-rays are always required for me because, like I said, I can't see from the outside if you have bad arthritis or not. And depending on what the x-rays show, sometimes we do an MRI to look more carefully at the soft tissues like the rotator cuff and labrum. So here's an example of a shoulder x-ray, very similar to what you saw in the hip and the knee. The bone looks a little bit harder in the joint surface and it looks narrowed. And similar to other areas, the bone kind of tries to compensate for that lack of cartilage by making more bone to spread out that stress. So you see that very large spur on the bottom of that ball. So a lot of information about the treatments, but as you can kind of hear from me, non-operative is certainly a good option, and it's a very good place to start because it's always a big commitment to undertake these surgeries. And the times to consider is when those things that, like physical therapy and injections, are no longer helping you. It's really affecting your quality of life and ability to do what you want to do. And talking to us about what the next step is for you. And it's really about deciding what's best. I just like to empower people to have information to make their decisions so that you can feel comfortable with your decision. So similar to what Dr. Robbins said, the diagnosis is really key for me to help you decide what options are available for you. And many of them can be done without surgery. And obviously surgery is there for you if some of those things don't help. So thank you very much for your time. Welcome any questions. Yeah.
What's the pain level on the reverse shoulder?
So he's asking what the pain level of a reverse is. Those are always great questions and I think are relevant for any joint replacement because a lot of times people have tolerated pain for a long time. And so often people have the surgical pain as far as more of a sharp pain from the incision itself. But a lot of that pain that you were having from the arthritis or dysfunction is no longer there. So it's a little bit of a trade-off. And it varies from patient to patient. Another good question, recovery. So reverse specifically. So most shoulder surgeries require about 6 weeks in a sling. And then after that, it's physical therapy. Usually 4 to 5 months, I say, for people to get back to about 90 to 95%. I generally suggest it to patients as it tends to be more comfortable because some of the swelling goes down instead of staying right by your shoulder. But as long as you're in the sling while you're sleeping, you're safe.
What kind of damage does dislocations cause?
So he asked what kind of damage dislocations cause. It depends a little bit on your age. So younger, so I'm talking more teenagers, typically injure the labrum and sometimes the bone of the socket. And they're much more likely to redislocate or have instability. As we move sort of above 40, people tend to tear their rotator cuffs when they dislocate, actually. So that's why an exam is always very important to me after a dislocation, especially in that age group, because tears do a little bit better if you repair them sooner in that situation.
Coming back to the pain level, how would it compare with a knee?
He's asking how would pain level of a reverse compare to a knee? In the spectrum of replacements, hip is typically the easiest to recover from, shoulder somewhere in between, and knee is the most challenging. Anecdotally, I don't know if I have any data on that. Any other question? Anyone? Yeah. She's asking if we do any of the local or stem cell treatments here. Fortunately, I was just at a conference that I was listening to a lot about the biologic aspect, and it's a very hot topic, especially within sports medicine. There's kind of a lot out there and a lot that are talked about. What I would say is that the protein-rich plasma is one that probably I think is being hit a little bit more. There's a lot of different companies that will process it for you, and it's important to make sure that paying attention to the process that they're using. There may be some evidence there for knee arthritis to get PRP. I'm not totally convinced, so don't offer it to my patients yet. I just talked to you about it. Stem cells is probably actually a misnomer. The amount of stem cells is like 1 in 100,000 that they actually harvest from those different locations. Right now they're using fat as well as bone marrow, and there may actually be a little bit more credit to the fat right now, but I'm still waiting on the good studies to come out. She asked if we have our own physical therapists on staff. Heartland Orthopedics does have a physical therapy department that's right next to us, but I've had great experience with all the therapists in the area. And for me, it comes down to patient preference and what's convenient for you to do. Looks like that's it. Thanks so much for listening.